So this is just a little recorded overview of COPD and asthma. Apparently, I uploaded the slides on COPD and asthma that had me talking, and I did not mean to do that. So those that listen to those slides, I apologize, and I hope nobody else does. They were very long, and it can only help you. So COPD, please remember that COPD is not reversible. It is characterized by chronic airflow limitation. It's the fourth leading cause of death here in America. It costs our healthcare system over $50 million every year, and up to 14 million people have COPD. These are little Khan Academy videos that I think are great that discuss the pathophysiology of emphysema and chronic bronchitis, so to kind of help you understand the difference. Basically, what the videos are saying, but the videos are so much better at it, is that in emphysema, you have your alveoli, which are like the functional unit of the lung, and in emphysema, what happens is those little alveoli become one big alveoli. And so basically it decreases the surface area for gas exchange to occur, which results in all of the symptoms that you see. So they have a hyperinflated diaphragm, they have a barrel chest, and they tend to be older and much more thin, because of the fact that they get so short of breath that they are not able to really eat very well. The shortness of breath that they have causes them to be malnourished because that expends a lot of calories and they can't consume a lot of calories. And then their chest is a little bit more quiet than a chronic bronchitis person, because the chronic bronchitis person has a lot of mucus. So in chronic bronchitis, they have mucus in their bronchioles, and so they're coughing up all of this mucus, which causes air exchange to be impaired as well. And they are probably also at risk. They are at risk, they're not probably at risk, for ineffective airway clearance because of all the mucus buildup. The chronic bronchitis person tends to be a little bit more overweight, more cyanotic. They are more at risk for right-sided heart failure, so they might have some peripheral edema because of that. Their hemoglobin is elevated because their body is trying to make more hemoglobin for oxygen to attach to, and they're going to have more wheezing and more crackles because of the mucus that's going on in their lungs. And both of them are going to be short of breath, but the emphysema person is probably more short of breath, and they both have a barrel chest, but the emphysema person is more pronounced because they're so thin. They're both older, and they're both going to have clubbing of their fingers. So the risk factors for COPD, smoking is like your big risk factor. Then you have environmental smoke, like if you have a secondhand smoke, can be a risk factor. Occupational dust and chemicals, infection, the pollution in the air, indoor and outdoor. And then another factor is the alpha antitrypsin deficiency. So people who have alpha antitrypsin deficiency, like maybe have never smoked in their life and they have COPD, but that's a very rare population. So manifestations, like I said, shortness of breath. That's your very first manifestation that you're going to see. And then you're going to have a chronic cough and sputum production, especially with somebody that has chronic bronchitis. Diagnosis is based on the lung function testing that Charlie talked about in the when we did the teaching presentations. So the diagnostic criteria is that you have a forced expiratory volume of less than 80% and a ratio of this forced expiratory volume over the forced vital capacity of less than 70%. So somebody who has a ratio of less than 70% on this lung function test that's diagnostic of COPD. If it's less than 70%, it's mild COPD. If it's 50% or less, then it's moderate to severe COPD. And remember, that is the amount that you are able to forcibly exhale over 1 minute, over how much you're able to hold into your lungs, that ratio. So the management of COPD. So the big thing is you want to have them stop smoking. So smoking cessation is a priority. That's a health promotion, and it is management of the COPD as well. Then we have bronchodilators, and you have metered dose inhaler and spacers. Your bronchodilators can be your short-acting, your anticholinergics, and your sympathometics. Your short-acting is your albuterol. That's prescribed PRN, basically, to help somebody who is having an exacerbation of COPD, to help them throughout the day, that they can use if it's getting worse throughout the day. Whereas, so again, your short-acting bronchodilators, like your albuterol, is going to be a PRN type medicine, whereas your anticholinergics, your inhaled steroids, your mast cell stabilizers, those are more going to be a daily type thing, and it's more for underlying control. You can have an inhaled steroid or a systemic steroid. Please remember that with inhaled steroids, you're not going to have the same systemic effect. So somebody can stop an inhaled steroid and it's not going to give them the same types of issues as a systemic steroid, a steroid that's given IV or PO is going to have. So what are the systemic effects of steroids? Hyperglycemia, decreased immune system, Addison's disease if you withdraw the steroid abruptly without tapering it off. So you always want to taper a steroid off. But an inhaled steroid is going to give somebody, it can give somebody thrush. So you want to make sure that you educate them to wash their mouth out, rinse their mouth out after each time they use that inhaled steroid. Remember, theophylline, which is considered a bronchodilator, is used, but it's not used as much because of the fact that you can have toxic effects from it. It has a very narrow range of therapeutic range. Some toxicity side effects to look out for: tachycardia, nausea, and diarrhea. With your albuterol, again, those can cause, since they're bronchodilators, they're going to kind of rev you up because they're opening up your bronchioles, and you're going to have tachycardia from that as well, from a bronchodilator. So that is something that you want to keep in mind. For somebody with COPD, they need oxygen therapy. They might need surgery. Usually surgery is something that is kind of the last resort, and it's more for improving quality of life than anything. But it's not something that's done first line. And then there's pulmonary rehabilitation for people. So pulmonary rehabilitation just kind of will help them be able to manage their COPD better, be able to have exercise tolerance, those kinds of things. So, do I have the answer to this now? So the nurse is teaching a COPD patient about his newly prescribed corticosteroid. The nurse should explain that the drug is used for. So what are steroids used for? They are given to help achieve longer-term control of your symptoms. Relieving bronchospasms is what the short-acting bronchodilator is going to do. Curing the underlying systemic infection is something an antibiotic is going to do. And preventing recurrent pulmonary infections is something that, managing your COPD will help. You are not going to necessarily be able to prevent something. So exacerbations have been linked to acidosis, pneumonia, atelectasis, pneumothorax, pulmonary arterial hypertension. This is why we need to manage exacerbations and not let them get out of hand. So nursing management of the patient with COPD, you want to do a health history, you want to question them about dyspnea, about sputum production and cough. You want to do a physical exam, which is going to be focused on their breathing pattern and their body position. So the first thing that you want to do when you're examining them is assess their respiratory status. Some goals and interventions need to address promoting the smoking cessation, managing their chronic dyspnea, managing their impaired gas exchange, managing their cough, promoting nutrition, preventing complications, enhancing self-care strategies. Diagnosis is involved with improving their ADLs and their respiratory function. That's how you're managing their COPD. You're giving them education about things that they can do to make their COPD improved. It's not going to go away, but they can manage it and have better quality of life because of that management. A nurse teaches a COPD patient to not smoke because smoking. Does it A, increase the amount of mucus, B, decrease the amount of mucus, C, shrink the alveoli in the lungs, or D, collapse the alveoli in the lungs? Well, it increases the amount of mucus production. It increases the production of mucus by basically irritating the cilia, irritates the goblet cells, and this causes more mucus to be produced. So asthma, let's not get COPD and asthma confused. So with asthma, is characterized by variable and recurring symptoms, airflow obstruction, and bronchial hyperresponsiveness. Asthma is reversible. It is an inflammation, and it's caused by, basically something has caused your immune system to go haywire, basically. So asthma is going to affect more young people, more young adults. Not saying that older people don't have asthma, but you're going to see it more in the younger population. And then I believe there's a video about the pathophysiology of asthma, which I think is great to watch. Some risk factors for asthma is basically an IgE-mediated response, which the video talks about. It's your immune system not doing what it should be doing, or basically overactive. Allergies, seasonal allergies can trigger it. Genetic and environmental factors can trigger it. So as people who have asthma are very vulnerable to your ozone effects. The diagnosis is based on our history, physical examination, and spirometry. The doctor is going to do all that, but that is how somebody is diagnosed. Most common manifestations, cough, dyspnea, and wheezing, because you have bronchoconstriction, so you're going to have your wheezing lung fields. The management goals are controlling our symptoms, maintaining their pulmonary function and their activity, preventing recurrent exacerbations, and educating our patient. So this is the picture of a peak flow meter. A person who is asthmatic, the nurse is going to teach them, not in the hospital, but in an outpatient type setting. So somebody that's going to their primary care provider. and they've been diagnosed as having asthma, they're going to be given this instruction on a peak flow meter. And so daily they're going to blow into this peak flow meter, and it's going to have on this meter green, yellow, and red. And if they're in the green, they are good to go. If they're in the yellow, they need to take caution with what they do because they're more likely to have an asthmatic attack, and they might need to, take a puff off their inhaler. And if they're in the red, then they are, boop, boop, stop. You need to go to the ER probably is what they need to do, but they might, want to call their primary doctor because they don't want to go to the ER. But if they're in the red, they should get medical attention. So these are pictures of what peak flow meters look like. So again, we have pharmacological therapy, which we have prickly leaf medicines, which is the short-acting medicine, the short-acting bronchodilator, the albuterol. And then we have our long-acting medicines, which are like your steroids, your stabilizers, those types of things. You can have a mild, moderate, severe, life-threatening exacerbation. It just depends. One of the very pertinent questions that you want to ask an asthmatic after you've gotten their asthma attack under control, or maybe they have a family member there, have they ever been intubated before? Because if somebody's been intubated before and they have asthma and they're having an exacerbation, they are more likely to be intubated again. These exacerbations can be complicated by having other issues, other underlying diseases, comorbidities, can be complicated with status asthmaticus and respiratory failures. And the interventions of these are going to focus on getting the exacerbation under control and preventing any complications from developing. So here's some breath sounds if you want to listen to them. A camp nurse is providing immediate care for a child who's having an asthma attack. What is the preferred treatment to alleviate the patient's airflow obstruction? And I hope everybody got this as beta-adrenergics because that's what you need, short-acting beta-adrenergic. The nurse is taking a history on a patient who reports sleeping in a recliner at night because lying in the bed causes shortness of breath. How is this documented? Paroxysmal nocturnal dyspnea, because they are having dyspnea at night, so that's what the nocturnal is. They're short of breath, that's the dyspnea. And paroxysmal is that it's intermittent. A 35-year-old male arrives in the ED following an MVC. He is alert, but he's having chest pain. His ABGs reveal a pH of 7.26, a CO2 of 60, and bicarb of 2024. What is he in, and is he compensating? He is not compensating, which I don't even have that, and he is respiratory acidosis because his CO2 and his CO2 is high, his pH is low. What is the best position for a patient to assume for thoracentesis? Is it side lying, affected side exposed, lying flat with the arm on the affected side, sitting up, leaning forward over the overbed table, or prone position with the arms above the head? Well, a thoracentesis, they're going into the lungs, so they need to have their lung filled kind of opened. So what can open their lungs so that the provider can get into their lungs with a needle? Well, they can't lie flat with their arm affected because if you lie flat, it doesn't really open your lungs, right? If you're prone position with the arms above the head, that doesn't really open your lungs because the provider needs to get to the sides of your lungs, right? Or maybe to the front. So maybe that's side lying with the affected side exposed with the head slightly raised. Well, again, if you're lying on your side, your lung fields aren't really going to be open. So what you want to do is to sit up and lean forward on the overbed table because sitting up helps open up your lungs, it helps get those lungs open, and leaning forward will help get the intercostals separated so that the provider can get in there. All right. So some things that you want to take away. So think about some signs and symptoms of hypoxemia. So what does hypoxemia mean? That their blood oxygen is low. So that if their blood oxygen is low, are they getting oxygen to their organs? No. Are they getting oxygen to their brain? No. So what kind of symptoms might you see neurologically? Altered mental status. What else might you see neurologically? Maybe they're irritable because their brain is not getting the oxygen. They're obviously going to be short of breath. They are going to be tachycardic because your body is trying to compensate for this lack of oxygen. You're going to be sweating because your body's trying to compensate. You're going to be turning colors because you don't have enough blood or enough oxygen in your blood. These are things that you might expect to see. Let's not forget that albuterol is our short-acting medicine. It's a bronchodilator. It's going to help stop wheezing. It's going to help open our airways because it's a bronchodilator, so it's going to dilate those airways. If it dilates our airways, are we going to be wheezing? No. If it dilates our airways, are we going to be coughing? No. It's going to make us tachycardic because it's albuterol, and that's one of the side effects of albuterol is tachycardia. Please know how to use an MDI and how to use an MDI with a spacer. It's very important to be able to teach that to a patient, so you need to know how to use it. So I hope this helped. If you have any questions, please visit on the discussion board. Thank you.